Good morning, everyone. That was such a wonderful introduction. A pleasure to present that. On my way here, maybe some of you don't recognize me anymore. Something's new with me, right? On my way here, one of the guys at the booth said, "Uy, foreigner na itong speaker this morning." Ay puti ang buhok. So it's really an international event for this year. So I'd like to thank my buddy, my good friend David, for of course Giselle, for really going out their way to organize such a prestigious event. This is really tough to organize. You know how it is, right? It's like a thankless job, and they've been working hard since like 3-4 months ago. So can we just give them like really a round of applause for really working hard for us to be here. And also, it's an honor to have this distinguished gentleman in front of me. Murag ko yun sa mag-lecture kay naadire atong big boss. So, thank you guys for coming. Who watched the game last Sunday? Wala? Everyone, right? 0 crime rate in Cebu, right? Because of this guy. And when you were watching, I wasn't able to watch. But I just heard that it was a great fight. Was it? Did you I reviewed the video and I just realized that these guys were hitting each other like crazy, right? And Thurman, who is much bigger than Pacquiao, was actually hitting him right on the face. Do you know that? Did you watch the game? Now, let me ask you this very simple question. Did you ever think about this? Why is it that Pacquiao was able to resist the impact of Thurman's punches, and while Thurman wasn't able to resist the first blow that hit him? What's the difference? What's the difference? Exactly. It's the facial type. It's the muscles on the chin that resisted the impact. And you know how is it developed? From years of eating bayabas, mais, and hakko kamote in Jensan, compared to Western diet, which is soft diet. That is the game changer in this game. And that guy was able to resist the big blows. So you can see the difference in the arch form. You can see the difference in the arch shape. See the difference? The arch form, the brachycephalic facial features, the wide arch, the V-shaped arch, and guess what? Based on my research, Thurman is a product of old school orthodontics. He had 4 premolars pulled out. That's why he had a V-shaped arch. Yes? You know what Pacquiao did? He hit him here first, and then hit him here. And then down he goes. What is that? That's airway. You cut off the airway, and you hit the head just like that, you go down. Okay? So, that ends my lecture. Thank you. Alright, so, to cut the story short, I've been into this journey of orthodontics since as far as I can remember. I've always been a guy who is never satisfied in doing the same thing over and over again. I've experienced so many difficulties and challenges along the way. And of course, my personality is, I don't take it sitting down. I always learn new things. And these are the 2 guys that has dramatically made a difference in my orthodontic career. If you want to know more about what I do, these are the 2 guys. These are the go guys that you want to go for. Okay? Now, if you know him, Dr. Bill Han, he is the founder in the US of ERRS. What is that? Extraction, retraction, regret syndrome. He is an orthodontist. He's been pulling out premolars all his life. And guess what? He regretted every single premolar that he pulled out because he realized that why is it that we are pulling or removing a part of our organ that doesn't have any problem? Are you with me? Does that make sense? Is that medicine? It's not. It's aesthetics. And that is not medicine. What I'm pointing at here is that we need to look at how we look at our patients, how we look at our patients on a day-to-day basis. What is our priority? What is your priority? You people at the back. When you treat a patient, what do you value the most? Tell me, is it aesthetics or health? Health. Yes, because we are doctors. We are physicians of the mouth. We are the guardians of the mouth. To put it technically, we are the guardians of the craniofacial complex. We are doctors, and we are not mechanics. Right? So these are the two guys. The other guy that you want to go for is Dr. Michael Gell. He's an orthodontist. Take note, they are orthodontists, but they have shifted towards this. And if you want to know more about his work, you can Google it. You can always listen to his talks, beautiful talks that he does on YouTube. And you will learn a lot from these guys. So, one thing that he points out, and he really advocates Airway. So one thing that you need to know is this. When you look at the case, from this day onward, when you go out, go back to your clinic, the first thing, if you believe me and trust me, the first thing you look at is the airway. Next, TMJ. Third, muscles. Fourth, what's the fourth? Orthopedic, and guess what's last? The teeth. That's the last thing you look at. If you want to practice orthodontics the most fulfilling way, you do it in that order. And you will realize later on as I show you my slides. Therefore, if you don't get the airway fixed, you don't get anything fixed at all. Okay, so what is this? This is a global epidemic. This is an epidemic which has affected our children, ourselves, universally, globally. 80% of our kids have this. It's called craniofacial dystrophy. What is that? To make it simple for you, it is everything is downsizing. In other words, the muscles are no longer functioning the way it should be. There is a loss of muscle tone, and the airway is becoming smaller, the mandible is becoming smaller. Kids are no longer sleeping the way they used to. Kids are no longer eating the right food. They are not masticating very well. And guess what? Where does it all lead to? It leads to this. Soft tissue dysfunction is affected. Airway, STD. Sleep is affected. And the patient develops at a young age OSA, or obstructive sleep apnea, at a very young age. Now guys, listen. In the study of longevity, if you are into that, I am into it. My passion is longevity, not just for myself. That's why I do Ironman. Because my passion is, I pray to God that I will be able to still do what I'm doing now until I die. Patay gihapon. But I will be able to do the things I do now until the last moment I die. That is longevity. And guess what? What's the secret to longevity? 4 things. If this is the only thing you'll learn from me, 4 things. Number 1, of course, we know that. It's diet. It's your food, right? Yes? Okay, second, what's next? Exercise. Do you exercise every day? 30 minutes, 3 times a day. So 3 times a week is all you need. Do you exercise? Do you let your lungs work? Third, do you manage your stress? Stress is a very, very big factor in cortisol. Cortisol is a sleep killer. If you are stressed out, you don't sleep. Yes? Or do you agree? Yes. And guess what? The last one, the most important among all the four is sleep. Sleep is the most important among the four. Can you imagine that? You know the average time that 100 years ago, how many hours do we sleep? On the average, 100 years ago, human beings, 9 hours. Thank God to bulbs, electricity. Guess what? How many hours are we sleeping now? How many hours did you sleep last night? Tell me, how many hours did you sleep? 6, 7 at the most. Right? Yes? See, some of you are yawning. If you are yawning now, and you're sleepy now at this time, you have a problem. You might have OSA or obstructive sleep apnea. Guys, this is medicine. If you have a problem with sleep, sleep has its comorbidities. And that is what you see on the screen. I cannot explain all that one by one. But these particular problems that we have, like orofacial pain and TMD, guess what? Orofacial pain and TMD is not about splints. It has a lot to do with sleep or airway. Because there is such a thing as sleep disordered breathing, which affects your sleep. And it is a very common problem. You know how many percent of us have OSA in the Philippines? In a study done, there's about 25 to 30% of us have OSA. What is OSA? Obstructive sleep apnea. In other words, you are not sleeping. And if you are not sleeping, you will develop metabolic disorders like cardiovascular diseases, diabetes, all sorts of problems like orofacial pain and all sorts. So, we need to look at this condition. This is a global epidemic and it is affecting our children. And guess what? Who should look at these patients first? Is it an ENT? Is it a pulmonologist? It is the dentist. It is us. We are the first line. And if we are not going to screen these patients for sleep disorders, then we are committing a mortal sin to our patients. Because we are responsible for them. Yes? Are you interested to know more about this? Okay. There's a lot of people at the back. You might want to join us here in front. There's a lot of seats in front. Sen, okay lang? They can move to the front. There's a lot of people at the back. Okay? Alright, so, what's the worst human diet? I want to start first with, what is the cause of all this? Why is this very common now? What is the problem? What is the cause? There are two things I want to discuss. Later on, I'm going to talk about the symptoms and how to address. But first and foremost, I want to talk about etiology. What is the cause? What is the problem? Why are we having this problem now? It's a modern day disease. Guess what? It's our food. That's the number one problem. It's your food. Your choices of food. Okay, can I ask you a question? What did you have for breakfast? What did you have for breakfast? Okay. Now you know why you are sick. On the average, listen, on the average, we are consuming 3 times more sugar than what we require. On the average, we are consuming 400 calories of sugar every day. Others even more. You know how much you need? How much sugar you need? You know how much sugar you need? 150 calories of sugar. That's all you need. What is that? 1 cup of rice. That's it. Okay, so this is the number one problem. It's a soft diet that we have. It's a typical Filipino breakfast for our kids. That's what we have. It is highly inflammatory. It's a highly inflammatory food. It's processed food. It's highly inflammatory. It promotes pro-inflammatory cytokines. And it is affecting our youth. It is affecting us. If you want to know more about that, I am very much into ketogenic and intermittent fasting. I fast like 4 times a week. I don't eat breakfast, and it helps me a lot. Maintain my 29 waistline. Thank you. So, what are we talking about here? We were taught by our parents that our children should be eating soft diet. Lugaw, gerber, baby food, all these are soft diet. Yes? At the age of 2 and 3 years old, they should be eating hard food, semi-fibrous food. Do not mash the food. Do not mash the potatoes. Do not mash the apples. Let them eat the apples, just like what Aling Junisha did. Are you with me? Let them masticate their food. Work it out. Otherwise, it will not develop, just like any muscle of the body. Give them a hard time. The problem with us, we always want to facilitate, make things easy for our kids, yes? Pasakin nyo lang, school bus yung anak nyo. Make them become tough. Because we are so scared of them, right? So, we need to look at how we eat our food. It should be raw as much as possible and unprocessed. So, why did I say that? Because about a year ago, if you remember, or maybe months ago, if you remember this, who has read this? It was actually on front page. That they discovered fossil remains of humans in the Philippines, in Sierra Madre. Do you remember that? 2,000 years ago, fossil remains of human. These are our ancestors. Guess what? What have they discovered? No malocclusion at all. No cavities. In other words, walang dentista. Arches are wide, and guess what? What's the indication that these kids are eating well, or these people are eating well? Third molars are all present. Look at the third molars. They're all erupted. Yes? Okay, let me ask you a question. How many percent do you think our third molars become impacted now? Give me an idea, sir. 9 out of 10 are impacted. And that's an indication na hindi pwedeng magkamali ang Diyos. Na hindi niya pwedeng bigyan ng space yung ngipin na yan. Yes? So, we have a problem. Do you admit that? Yes. Okay, so, this is one indication now. If you remember, are you okay? Are you interested? Okay, thank you. If you remember, Orthodontics, 6 keys to occlusion. You remember that? Who remembers? Orthodontics, 6 keys to occlusion. Guess what? That's old school. Throw that away. You don't need that. Because it's all dental. Yes? It's all class 1 molar, class 1 canine, overjet, overbite, midline, blah, blah, blah. It is important, but that is not to be your priority. These are the 6 things that you need to look at. Not in its particular order. Okay? First, we call the 6 keys to optimal ortho outcomes. Number 1, growth. Growth redirection. Kids who are mouth breathing have a vertical growth direction. In other words, they are growing with a long face. They are growing vertically. If they are growing vertically, we need to convert that from vertical to horizontal or downward and forward growth, which is the ideal growth direction. So, if you remember, so this is please take a look. This is the vertical growth direction, and this is the normal direction. If you remember your orthodontics, these are patients with open bite, long faces. That's the vertical. This is the normal growth. Now, I want you to observe the space at the back of the second molar, and that is this space here. Do you see that? Which has bigger space at the back? Normal grower. In other words, listen, the same length of the mandible will produce more space at the third molar area if the growth is more downward and forward. And what is the impact of that to airway? Bigger airway if downward is downward, if growth is downward and forward. Now, what is that? If you look at the patient, this is a vertical grower, and this is that's your horizontal grower. From vertical to horizontal, or downward and forward rather. So we need to change this. We need to look at this. Growth redirection. Second thing, airway. Airway is big. You know that. You can see that from the Ceph. When I look at the Ceph, I don't look at the numbers. I look at the airway first. Remember what I told you at the onset? Airway first. Look at the airway. You need to fix that. Otherwise, you will not be able to fix anything. Look at the airway. So, this is a normal airway. This is how a person breathes. Okay? Oxygen is very important. You can live without food for months, but you cannot live without oxygen for 3 minutes. Right? Yes? So this is very important. So the first thing you look at is the nasal passage. The air passes through the nose, all the way to your nasopharynx, down to oropharynx, then down to laryngopharynx. That area should be clear, 100%. Alright? Now, what are the problems? We have choke points. We develop choke points. What is a choke point? It's a bottleneck that prevents us from breathing through the nose. So the child opens up to the mouth because of choke points. So what is the number one choke point? Turbinates. Okay, this is a very common choke point. And this is activated during with allergens, like allergic rhinitis. It swells, right? It swells, and it prevents the child from breathing through the nose. Alright, are you with me? So it is seasonal, it's not always. It's allergic rhinitis. But we need to work on this because sometimes it becomes chronic. Number 2, polyps. Magugulat yung pasyente ko. I take pictures under the nose. I take pictures just like that. Because sometimes we get to see that there is certain growth that is there. Yes? And number 1, most common is nasal polyps. It's very common. Very common. Nasal polyp. It obstructs your nasal airway. Number 3, deviated septum. Very common. 25% of us, we have deviated septum. For some reason, habit, maybe we had expansion when we were young, maybe rapid palatal expander. Deviated septum. What happens here? One nose is working, the other is not. It is totally blocked in one side. So what do you do as a test? When you go back to work tomorrow, you know you have this occlusal mirror. That occlusal mirror, you should be able to know if one side is working and one side is not. Do you see the difference in one side? So this patient has a deviated septum to the right. Okay? So you need to look at sometimes, totally there's nothing that comes out on one side. Seasonal allergies, very common. Nasal secretions, you need to clear that off. What else? Deep bolt. I used to think that I expand to create space. Right? Are you with me? But that is dental. I expand now because I need to develop the arch for bigger airway now. Why? Let's look at anatomy. Do you see this? Okay, that is the floor of the nasal passage, that red part. What is that? That is your palate. Are you with me? A deep vault is a narrow palate. If you have a deep palatal vault, expect that your nasal passage is smaller. So from this day on, you expand not only because you need space for dental alignment, but for for airway patency, call it, to open up your airway. Oh, adenoids and tonsils, very common. Very common, yes? This is already a standard for all our patients. We take photos intraorally. We look at that. It is a choke point. It is a choke point. It is a lymphatic tissue. It swells. The cameraman is sleeping. Keep quiet. My sleep disorder. Okay, now we have to grade our tonsils from grade 1, from 0 to 4. 4 being the worst, and this is what you call kissing tonsils. Grade 3 and 4 is usually indicated for tonsillectomy or adenoidectomy. Right? Now, another thing I want to discuss with you is tongue tie. Tongue tie is big. I know that there are patients with a tongue tie. Have you seen a tongue tie? Okay, very common. You know why it happens? Do you know why it happens? It happens during the embryonic stage. This particular frenum or attachment fails to detach, and it persists. And it prevents the tongue from moving up. Do you see that? That tongue is unable to reach the palate to support the palate. Okay? Now, why is it important? Okay, wait a minute. This is a okay, so why is it important? Okay, this is a tongue tie. Look at that. The tongue should not only be able to touch the palate, the tip of the tongue should not only be able to reach the palate, but the dorsum and the body of the tongue should be up against the roof. Why? The tongue serves as a scaffold for the maxilla, for this maxilla to develop, for this craniofacial complex to develop. The proper way is to be able to raise your tongue all the way up against the roof, all the way to even to the soft palate. So if your patients are unable to do it, then they have a tongue tie that needs surgery. Are you with me? Okay, so this is a patient which we did. This is before tongue tie. Now notice, this is the same patient in 1 month. I want to show you the difference. This is the same patient. Do you notice how he is able to move his mandible up to be able to, that's compensation. Are you with me? He's trying to compensate so that you will be able to reach the top. Now, this is after a month. You see that? That's the same patient. This is after a month of myofunctional therapy and after surgery. See how he's able to raise his tongue up, suck against the palate? That is how our patients should be, for us to be successful with our treatment. So please go back to your clinics later on, tomorrow, and check if your patients have a tongue tie. Guess what? Because if you expand and you don't address the tongue tie, guess what happens to your arch? Relapse. Because you are unable to support the mechanical expansion that you did. So this patient came to my clinic. She's a daughter of a missionary, and she's a sick girl. You can tell from her face. She hasn't been sleeping very well, according to the mom, and you can see a lot of issues here. Definitely a tongue tie. Definitely a tongue tie. You know why? You know the first thing you ask? If the patient has a tongue tie, you don't even have to look. Ask the patient. Or the mother, did you breastfeed? If the mother says no, why? Masakit. When I was trying to breastfeed my child, it was painful. Why is it painful? Because there's no latch. The tongue is unable to latch because it's tied down. That's why it's painful. So that's one. Second question, is your daughter or child prematurely delivered? If they are, most likely they have a tongue tie. Are you premature? Check your mouth. Okay. So this girl came to my clinic. She's sick, really sick. Narrow arch, crowding. You know the sad thing here? If you are not trained to do this, if you are not trained to screen, you will tell this patient, see me when you're 12. Why? Because your teeth will be complete by then. That is a mortal sin. Because this child will not thrive. She's not breathing well. She's not sleeping well. Move forward with diagnostics. Look at that airway. Zeros. There's nothing there. Do you see that? There's nothing there. How can you expect her to breathe through her nose? So she breathes through her mouth and malocclusion happens. Why is it happening? Swollen tonsils and adenoids. So obviously we refer her to an ENT or sleep medicine for two things. For a possibility of adenoidectomy and tonsillectomy. A sleep doctor should be able to do a sleep study or a PSG to determine if there is OSA or obstructive sleep apnea. Okay, now, can we turn on the volume? I want to show you this picture of this patient. How come there's no volume? I want you to listen and look at this child, how he's breathing. Okay? Now, don't laugh. This is not laughing matter. This is a ticking time bomb. This child will never be able to thrive. He's not sleeping. Now, look at the mom. Mom's holding the chest. Why is the mom holding the chest? There is arrhythmia, palpitation. You know when it happens when you have palpitation, when you're running. It's like you're running a marathon overnight. Are you with me? Are you supposed to be sleeping at night and resting and digesting? Yes? Yes. You need to sleep, but these kids are not. And it's very common. It's very common. Now, what is the problem here? These kids will develop at an early age arrhythmia. If you're an adult, you will develop cardiovascular diseases if you have this. Diabetes, because you become insulin dependent. Insulin resistant. Now, what is the cause of ADHD? If your kids were diagnosed with ADHD or ADD, you have to have them tested for airway. Because the usual treatment of ADHD is Ritalin or Adderall, which calms them down. But what's the side effect? It's a sleep killer. It kills their sleep even more. Now, what's the cause of ADHD? These kids are not sleeping. The following day, when they go back to school, for them to survive the day, they have to be hyperactive. So ADHD is not a developmental, it's not in the brain, it's in the breathing, and it's affecting the brain as well. So these kids will never be able to thrive. So what did I do? I did expansion. Because the parents, guess what? The parents are missionary, and the parent doesn't have the money to spend for adenoidectomy and tonsillectomy. So I just said, okay, let's pray for her. And we're going to just do 3 things in the next 6 months. Expand the arch, convert the breathing from oral to nasal, and do a tongue-tie release, which I did. That's all we did. No adenoidectomy, no tonsillectomy. And so, this will happen after 4 months. Guess what? 4 months after, no surgery done. Do you see the difference? This is 4 months. You see the face. Guess what the mom reported? Dr. Urbi, thank you. For the first time in my life, I have seen my daughter sleep that deep. Wow. How can that be? Number 3. Joints should be decompressed. Okay? Joint should be decompressed. Joint should be downward and forward, away from the disc. Downward and forward. What did our teacher in Prosto taught us in complete denture? Establish centric occlusion. What is centric occlusion? If you remember, centric relation. Define centric relation. The most posterior relationship of the condyle in relation to the glenoid fossa. What is that? That is a compressed joint. Sorry to those professors who teach that, but that is old school. The ideal centric relation is that the joint should be downward and forward away from the disc. And that is how it should look, anterior, inferior, mid position. Particularly Gels. I'm a follower of Gels. Now, why is this joint important? This joint is important because if you're not going to fix this joint will eventually deteriorate and it will lead to orofacial pain like migraine headaches. Right? So, this is a very common scenario, especially in ortho. It's called mandibular entrapment, where the mandible is pushed backward, up against the joint. And here we realize that we are moving our mandible all the way back for the aim of correcting malocclusion. And this is happening consciously or unconsciously. It happens all the time if you're not careful, if you're not aware. Remember what I told you, airway first and TMJ next? So, just to prove my point, guys, okay, so this particular article was, I read this article in 2012. Way back, 2012, that's like 7 years ago, it came out. And it simply says, this is taken from Anglo-Orthodontics. This is a journal for orthodontists. And it says there that whenever you extract premolars, you will affect the airway. You will affect the airway whenever you extract premolars, no matter what you do. So, you know, I do a lot of reviews. So this particular case I saw in one journal. And this is a journal for orthodontists, the one who does a lot of premolar extraction. And as I review this case is a premolar extraction. 4 premolars were pulled out, pads was used, orthobone screw was used. And this particular space closure is what you call maximum anchorage, right? So you close the space with incisor retraction. Now, this is the start, and that's the finish.